My pleasure to call to the stage Patrick Nachman and Elisa Thompson. Patrick is the professor of medicine at the University of Minnesota, and his research efforts pertain to the study of glomerulonephritis and small vessel vasculitis. And Elisa, coming up here, clinical team leader in the Division of Cardiovascular and Renal Products, Center for Drug Evaluation and Research, CDER, at US FDA. She joined FDA in 2007, and her team focused on products being developed to treat renal-related indications. Patrick?
Good afternoon. So my task today is to give you an update on our project, which was first vetted to the group 2 years ago and started about 18 months ago, and we had a first update at last year's KHI meeting. The members of the work group are diverse from industry, the FDA, of course, NIH, and also, we're really very proud to have 3 fellows among us: Sonia Boyer in France, Rupert Major in England, and Judith Schimpf in Germany. So really what we wanted to look at are what would be good surrogate endpoint for clinical trials in IgA nephropathy. Even though it is probably the most common GN in the world, it is still a rare disease, and the time course of progression to end-stage kidney disease or to a substantial loss of kidney function is long, which are the challenges that we've been hearing about in doing clinical trials with such diseases. So we, very much like Dr. Milliner mentioned, we started by looking at a whole slew of potential candidates that could be looked at as surrogate endpoint, and we ended up focusing on proteinuria reduction, not because it's the best or the end-all and be-all, but this is where all the data is. The other candidates had relatively slim data in supporting such analysis. So this is a slide that I presented last year. It's been modified a little bit, but our first task is asking, should proteinuria reduction be used as a surrogate endpoint in clinical trials of IgA nephropathy? The data is convincing, has very robust data that persistent proteinuria is a strong risk factor for progressive loss of renal function in IgA nephropathy, and unlike other diseases of the glomeruli, relatively modest degrees of proteinuria are a risk factor for loss of renal function. If you look at the literature and the trials that were done, there's really no uniform way of defining proteinuria reduction. Is it a % decrease? Is it down to a certain threshold? And there's no good consensus of this. When we looked at clinical trials in IgA nephropathy, we were very happy to see that Leslie Inker's group really did a beautiful meta-analysis of interventional trial. And what that right-hand side panel is a trial-level meta-analysis of the effect of treatment on proteinuria reduction and whether that effect on proteinuria reduction is associated with an effect on protection of kidney function. And you can see there that there is a nice slope, a graded relationship between the effect of treatment on proteinuria reduction and its effect on protecting from progression of kidney disease. So in 2016 and 2017, what happened is that 2 important landmark clinical trials in IgA nephropathy were published: the STOP IgA nephropathy trial and the testing trial. And just very briefly, the STOP IgA did show an effect of treatment on proteinuria that did not translate in an effect on a long-term outcome of patients. Testing was a steroid trial where there was an effect on proteinuria reduction. But so a year ago, when I showed the previous slide, we were concerned and we were asking whether these two large important trials would modify this relationship between the effect on treatment and the effect on preserving renal function. And the principal investigators of these two trials provided us with the data, and Leslie Inker's group and Kevin Carroll were able to reanalyze and to redo the meta-analysis, and they've done it in two different ways, and the take-home message here is regardless of how we analyze the data, the relationship is confirmed and maintained. So the work group feels confident that proteinuria reduction is a reasonably likely surrogate endpoint and may be suitable for drug approval under the accelerated approval program. So we have a white paper. It's written. It's been reviewed and internally at FDA, and we are almost ready to submit for publication. We're waiting one reanalysis of really determining who this data is most applicable for. And we're hoping to submit this by July. So where do we go from here? If proteinuria reduction is a potentially reasonably likely surrogate endpoint, defined as a % reduction in proteinuria, which I would contend is really a new approach of doing this. And if it is used in a pre-marketing trial, the effect of the drug under investigation would have to be confirmed in a post-marketing trial. And the magnitude of effect on proteinuria that we would need to look at to feel confident that this would potentially translate into an effect on protecting from loss of renal function would have to be determined. We posit that this could be back calculated from imagining what the post-marketing trial would look like. And this is not, I don't think it's an easy task, and members of our group, some of them are here, Anna Maria Kaus and Barbara Gillespie, with other members of the group, are really trying to address this in a second paper. It's not going to tell us exactly how to do the trial, but to provide a general approach, still focused on IgA nephropathy specifically, but provide a method on how to approach a confirmatory trial design. Thank you very much.